Hi, everyone. Welcome and thank you for attending today's webinar, Are Future Public Health Leaders Prepared for Emergencies? Fresh Approaches for the Current Realities, presented by Springer Publishing Company and featuring the editors of the recently published textbook, Public Health Emergencies, Case Studies, Competencies, and Essential Services of Public Health. My name is David Diadana, and I am the senior editor responsible for the Public Health and Health Administration publishing programs here at Springer Publishing. For those who do not know much about Springer Publishing Company, we are an independent publisher known for innovative textbooks, professional references, and clinical products in the field of nursing, behavioral and health sciences, and medicine. Before I introduce the presenters, please note that this webinar will be recorded, disseminated, and posted on our website in case you missed any part of the presentation. And we will also be taking a few questions at the end of the presentation from the audience through the Q&A feature on Zoom. Please feel free to send along any questions as we go during the presentation itself. I'm delighted to introduce our speakers for this presentation. Dr. Tanya Telfair LeBlanc is a senior public health professional and scientist. Her career began as a disease detective in public health, and over the past 2 decades has led efforts to advance the science and evidence-based practice of public health emergency preparedness. She currently serves as an associate editor for the American Journal of Public Health and has been co-guest editor for 5 supplements to the journal on topics including the evolution of public health emergency management, medical countermeasures, and community preparedness, collaborating often with our second presenter, Dr. Robert Kim-Farley. Dr. Robert Kim-Farley is a professor in residence at the University of California, Los Angeles, Fielding School of Public Health. He previously served in senior positions at the LA County Department of Public Health, the Centers for Disease Prevention and Control, and the World Health Organization. He has extensive experience with public health emergencies, including the development and coordination of LA County's smallpox preparedness, response, and recovery plan, as well as coordinating public health disease control efforts for emerging infectious diseases and integrated bioterrorism preparedness program activities. He received special recognition by the regional director of the Southeast Asia Regional Office of the World Health Organization for his extraordinary dedication and valuable support during the emergency response and rehabilitation stages of the earthquake in Gujarat, India. Here is today's agenda. And with that, I'd love to hand you over to Tanya. Tanya, please take it away.
Thank you so much, David, for that very kind introduction, and welcome to our public health colleagues. We are going to start today's webinar with what is emergency preparedness? Next slide, please. Definitions vary based on function. These are 3 of the major definitions, but there are many others. Let's review the definitions just for comparison. Next slide, please. The Federal Emergency Management Agency has more of a structural definition based on planning, organizing, training, equipping, exercising, evaluating, and taking corrective action to ensure more effective coordination during incidents and response. The Red Cross, of course, would have a medical definition. Their definition focuses on activities and measures used to prepare for and reduce the harmful effects of disasters on human populations. The CDC has a public health focus and emphasizes the ability of communities to prepare for, withstand, and recover from public health incidents in both the short and the long term. These are the definitions that are on file, but next slide, please. There are often differences between what we think about preparedness and response and the actual realities of preparedness and response. This is sort of the Hollywood version of what we all come to put in our minds about emergency preparedness. There's a room full of a panel of officials with important technology around, phones to the president or the governor. The hero steps up and makes a wonderful decision and saves the day. Of course, this is a straightforward approach, and it's very orderly, but this only accounts for one small part of emergency preparedness. This is the perception. Next slide, please. But implementation of preparedness and responding to emergencies can be exceptionally complex and involve multiple stakeholders, civic and faith-based organizations, local, state, and federal agencies, community-based organizations, the medical profession, fire and rescue responders, law enforcement, local and state elected officials, and of course, citizens. Herein lies the dilemma. How does an emergency planner galvanize these disparate factions to maximize response capacity and build community resilience? Next slide, please. When pursuing a career in public health emergency preparedness, we must learn from what it takes to go from the decision-making phase to the implementation and sustainability of overall community preparedness and response capacity. It involves the building blocks of preparedness. Next slide, please. So what is emergency preparedness in reality? It's much more than strategic plans and drills. It involves multiple stakeholders, community relationships and resources. Communication strategies must be in place well before an emergency. Strengths and weaknesses of a community must be taken into account. And in essence, resilience must be built into a community long before any kind of emergency. Next slide, please. So let's think about the importance of community preparedness and look at some of the things that make communities resilient. Next slide, please. This is a preparedness pyramid, which represents a selection of foundational characteristics we believe support the development of a prepared community. This is not meant to be exhaustive. I'm sure you in the audience can think of some other characteristics that should be here, but this is a place to start. Preparedness is not bureaucratic notions of artificially defined capabilities. Preparedness depends upon a strong system in place to protect and sustain life during normal circumstances that can be resilient under strained circumstances. So starting at the bottom of the pyramid, we have the structural features of a society, which include healthcare, housing, socioeconomic safety nets for those who are under strained conditions, serve as a foundation. Going to the next box up, monetary and human resources must be available to prepare for and respond for emergencies. Some communities may be pressed to provide routine public health services and may not have the resources to devote to preparing for an emergency event. Next up, strong hospital surge and first responder systems must be in place. Over the past 10 years, 130 hospitals in rural areas have closed due to financial constraints, and 1 in 5 Americans live in rural areas. That trend is creeping now into cities, central cities. Just recently in the city of Atlanta, 1 of 2 of the major trauma center hospitals announced that it would close. That leaves the remaining hospital, Grady Hospital, under tremendous stress to fill the gap. Next up, a prepared community must have relationships among service providers, healthcare, and response teams. These teams must have ample time devoted to planning to work together for a seamless response when everyone is very clear on their roles and responsibilities. Next, planners and responders must have knowledge of the community composition, its strengths and its weaknesses. It must be aware of who lives in a community, its basic needs. For example, the number of elderly citizens, school children, disabled people, poor people, and so on. Plans for emergencies may be inadequate to meet the demands if you don't know who's in the community. So conducting risk assessments are essential. Strong, credible, far-reaching communication strategies are also important. I've noticed that recently, many people may not have an idea of what community emergency plans are in their communities where they live. They may not know where to go to get accurate information. If only some people are aware of the official communication channels and outlets, they may be swayed by misinformation spread on social media. Good emergency preparedness planners should endeavor to create access to accurate information to all of its citizens. So when we take those things into account at the bottom of the pyramid, emergency planners must develop community strategic plans for preparedness and response and conduct practices and drills. In addition, they must engage the community with these strategic plans and inform people about what they should do in the event there's an emergency. Consistent and broad community engagement is essential. And at the top of the pyramid, community cohesiveness is a critical asset. Are people in a community willing to support and help each other in the time of need? We should all seek to improve civility and mutual support in all of our communities. So with all of these things in this pyramid and this exhausting list of characteristics, we can see that not all communities may be prepared to meet an emergency situation. Next slide, please. An important tool for improving community preparedness is the Federal Emergency Management Agency's whole community preparedness concept. This is a wonderful way that considers the things that I just discussed on the previous slide. It suggests that community emergency preparedness planners should find out who lives in a community, find out what the needs are, make sure they're really clear on what needs to happen during an emergency, builds relationships over time, and hopefully sustain those relationships with organizations over time, and build community resilience. Some of the themes for understanding community complexity in the whole community concept include recognizing community capabilities and needs, fostering relationships with community leaders, building and maintaining partnerships, empowering actions at the local level, and leveraging and strengthening social infrastructure, networks, and assets. Next slide, please. What can we do collectively and individually about improving preparedness? Next slide, please. Before we do that, I think we should think about what are overlooked threats to preparedness. So we need to consider this and think about it very carefully. At the top of the list, the structure of society can be a threat to society. Threat to preparedness. Before a mass emergency, a social structure is assumed to be sound and cohesive, with individuals acting in ways to mutually support the whole. A healthcare system is assumed to work reasonably well, with most people able to access care, and a society's communication system is assumed to be efficient for delivering unambiguous, life-saving messages to a majority of the population. As we witnessed with COVID-19 and other recent national emergencies, weaknesses exist in the structure of our society, including stressed healthcare and public health systems, hospitals struggling to meet the demand of large medical surges, disruptions in medical supply chains, misinformation and disinformation spread among the masses, creating mistrust and fear. We should also look at demography and economy as a potential threat to preparedness. In the past 50 years or so, we've seen market shifts that have resulted in a classic hourglass economy with high-tech, high education, high-paid jobs at the top, and low education service sector at the bottom tier, which creates a cadre of vulnerable, low-paid hourly wage workers that don't have access to healthcare, sick leave, vacations, or other social benefits. In the 1990s, a well-known sociologist coined the term advanced marginality. This is a socioeconomic condition that's multi-generational and in which individuals or groups are systematically restricted from obtaining sustainable work and not able to enjoy the benefits of society. He applied these conditions to American, primarily minorities, and in France, immigrants. But I take his definition and I've stretched it to include individuals who are experiencing advanced marginality in the United States now, who are unable to find sustainable work and could be, living in their cars, could be homeless, etc. Well, if you're an emergency planner, you must take into account that you may have people experiencing advanced marginality in your communities, and your emergency plans needs to account for these individuals. The structure of the government may also serve as a threat to preparedness. The alphabet soup of government organizations that are involved in preparedness, the list of many of them are involved with sometimes overlapping priorities and functions. You have FEMA, Department of Homeland Security, Assistant Secretary for Preparedness and Response, the Environmental Protection Agency, and others. Sometimes don't always work together seamlessly. That can also be a threat to preparedness. And the way people feel about the government can also be a threat. Sometimes people lack trust in the government. And we as preparedness providers need to definitely work on our communities to help them realize that the government is us. We elect individuals. Also, new definitions of community may serve as a threat to preparedness. In the past, communities were created by people living and working within close proximity and building sustained relationships over time. These patterns of work and living have changed. People are becoming more isolated from real human interaction, spending more time in screen-based social or business networks, and sharing and reinforcing ideas in cloistered internet-based groups. These communities are becoming more symbolic and more what we can consider them to be imagined communities. So preparedness practitioners should understand that there may be people in their community that have connections to imagined communities, and those people may be hard to reach during an emergency to provide accurate information. Sustainability of community coalition building is always a challenge. As we know, many coalitions are sometimes built on charismatic leaders, and when that leader leaves, the coalition may collapse. As a public health emergency practitioner, we should realize that coalition building never ends. You're constantly building and repairing coalitions as we go forward, and we should keep that in mind as we're building preparedness coalitions in our communities. Rugged individualism and its consequences may also be a threat to preparedness. In my view, the big Achilles heel in America is the inability of our country to see ourselves as one people working together toward the betterment of the whole. Most of our cultural ideology and iconography are those of self-sufficiency and pulling oneself up by the bootstraps. When I traveled to Japan many years ago, even long before the pandemic, I witnessed individuals during the cold and flu season simply wearing masks to keep from spreading their cold and flu to others. No one had to ask them to do it. They simply did it for the betterment of the whole. We need to think about that example. And again, I cannot overemphasize factual, believable communication is essential. Misinformation and disinformation in siloed sources and segmented media markets are threats to preparedness. People might receive mixed messages, and that creates confusion in the middle of an event. And then at the end of this, there can be many other threats. This is just where I'm ending here. Absence of health equity can be a threat to preparedness. Disaster responses in recent years, particularly COVID, but many others as well, have unmasked the persistent, untackled social and economic inequities. Well, what is health equity? Health equity means that everyone has a fair and just opportunity to be as healthy as possible. The definition of health equity may appear to be difficult to apply, and in my view, we should think of this as an aspirational goal that can be operationalized using the 10 essential services of public health, our core functions. The 10 essential services of public health provide a framework for public health to protect and promote the health of all people in a community. Next slide, please. What have we learned from past emergencies? Well, let's start at the top. From Uvalde, I'm sure we learned many other things, but I'll just highlight a few on this slide. The Uvalde, Texas example, clearly people were not aware of who was in charge. Lives were lost because no one was sure who could make the decision to go forward to take down the gunman. With COVID-19, there were many things that we learned, but one thing was that we have a stressed healthcare system. And with Hurricane Katrina, many people who were left behind and who drowned were either disabled or did not have transportation to evacuate or the assets to evacuate. So this example highlighted that we should emphasize access and functional needs in preparation for emergencies. And in September 11th, communication concerns among responders was definitely apparent. And in all these examples, social determinants of health is something that comes into sharp relief as we witness that people without access to social, economic, and other resources are often left behind during disasters. Next slide, please. So what can we do as public health professionals to be more prepared? Starting at the top, we can expand our knowledge about preparedness and understand its complexities and comprehend the complex nature of preparedness. And number two, we can create awareness in communities. In other words, tell others about how important it is to be prepared. Number three, ensure that people in communities know where to go to obtain emergency information. Share with friends, neighbors, and family where to go to get life-saving information. Number four, get involved and advocate for national policies to make life better for everyone during routine time, and that would include disadvantaged populations. Number five, we should encourage public health students to take courses in preparedness. Next slide, please. Well, just expanding that a little bit, why should all public health professionals understand the fundamentals of emergency preparedness? Well, as we can see from the media, we're surrounded by the media. Hazardous threats are becoming more diverse, more numerous, and more frequent. Emergency preparedness and response are constantly changing. Knowledge of how local, state, and national emergency preparedness activities are conducted may save lives. An aware community is a safer community. It builds awareness of the communities in which we live to understand our critical needs and barriers, as well as assets. It builds capacity in the preparedness workforce by having additional trained responders. And it also aids in collaborative response efforts by having multidisciplinary professionals available for decision-making, preparedness, and response activities. Having multidisciplinary minds at the decision-making table ensures that more of the important aspects are covered during planning. And it creates awareness of the enormity and complexity of the task of preparedness. Next slide, please. And now I'm pleased to introduce my dear colleague, Robert Kim-Farley, who will share specific lessons learned during the COVID-19 pandemic.
Thank you so much, Tanya, and really appreciate that overview of preparedness that I think really sets the stage of having a chance for us to also talk about specifically what's going on right now and what lessons are we learning and what are we still getting wrong about COVID-19. If I could have the next slide, please. Perhaps one of the most important things has been the lack sometimes of clear, consistent communication, because that's really critical to maintain the public's trust and their support. We've seen mixed messaging from different parts of government. One advisory committee recommending this or a director recommending that. We have also seen at different levels of government, messages at national level differ from what's being done at state level, which might even differ from what's being done at individual health jurisdictional levels. So I think we certainly needed to have prepared and need to continue to try to prepare the population about the fact that we are going to change guidance. So, for example, this was a brand new virus. As we learned about the virus, our guidance changed. Also, the virus now itself has been changing, as we've seen with the mutants that have been arising. And so that in itself leads to different changes of our recommendations. It's not that public health is flip-flopping. It's just that the guidance is changing based upon our evolving knowledge about the virus and its own evolution itself. Next, please. I think also we have oftentimes heard the phrase, follow the science. And I think for us in science, we often think about that being the biological science. You know, we're learning about the transmission patterns of the virus, what things can be done, vaccines, et cetera, to be able to curtail its infection, transmission, and severity, et cetera. And that certainly is an important part of what the science is that we should be following. But I think we've come to realize, you know, there are other couple of sciences that we need to be also putting under that same follow the science umbrella, namely behavioral science. You know, what will people actually do? And that actually was one of the foundational reasons for example, the changing of the length of quarantine. The original 10 days, for example, after exposure, maybe only a third of people were following it. So we recognized, hey, better to go ahead and have it at 5 days, which is the most critical days, and also having more people follow that guidance. And thirdly, I wanted to bring up the aspect of political science. What control measures can be applied, for example, in China might be much different than what we could apply in the United States or Western countries. So I think that we have to realize the importance of following the science as a key factor in the control of infectious disease such as COVID. Next, please. The other thing that we all seen that has been highly unfortunate has been the politicization of the measures to control the pandemic. Although this is easier said than done to avoid it, I think we need to have found ways in which we could have done this. For example, COVID really should have been a bipartisan victory. One administration standing up and saying, look, you know, we developed the vaccine, and another administration standing up and saying, look, we're deploying the vaccine. Both should have been on the podium holding hands together and saying, look, we are united against this common enemy. Next, please. I think one of the other lessons learned has just, again, been the political and cultural realities that we face. There were many different control measures obviously applied: isolation, quarantine, cordon sanitaire, which is basically sealing off an entire city or village, masking, vaccination. All of these things had different ways of being applied. And again, in China, with forced isolation, forced quarantine, the actual application of cordon sanitaire, which is rarely used in public health, but basically being able to shut down entire cities or regions of the country for any egress or ingress. So I think that those sorts of things have to be realized, that we have to look at what is the political realities and what can the public indeed abide by. Next, please. So I think also one thing I think I have certainly learned from it is that really there are three protagonists at play when we have any public health emergency, including COVID-19, that you have governments and their public health agencies. These are responsible for tracking the epidemic, being able to provide guidance, develop vaccines, deploy vaccines, testing, et cetera. But you also have businesses and schools who have to be able to follow these guidance and have to, for example, improve ventilation systems, be able to have screening of their employees before going into work. And finally, the third protagonist being the individuals themselves to actually be practicing these things. Really, unless all three of these parts of a three-legged stool, if you will, are in place, we do not have an effective control measure. Next, please. I think also the understanding and of being able to address controversy. I believe actually that COVID-19 has, interestingly enough, hit the sweet spot of controversy in this country. It's, let's say, approximately 1% infection mortality rate across the board. Let's say, for example, had it been 10 times less, 0.1%, that's even less than seasonal influenza. I think even us as scientists would have been saying, oh, look, interesting, got a new virus, we're gonna have to look at it, but we're not talking about shutting down schools, shutting down businesses and things like this. Had it been 10 times more, let's say at the level of SARS at 10% fatality, everybody would have been turning to public health and saying, look, I am losing family members, friends. What can we do more to stop this? Everybody would have been behind us. And I think that the recognition that that particular 1% has been a very tricky one for us, because you have one group of people would be saying, well, look, 1%, yeah, that's really bad to see people dying, but, what about the consequences of not having our children in school? What about the consequences of losing my job? Where others would be saying, every life is precious. We've got to do everything to save a life. Both have truth to them, but it causes the conflict in the society. And I think especially, again, for COVID, where, let's say, as compared to the Spanish influenza of 1918, which killed many young people, this was primarily killing older people and people with multiple medical conditions. So you had also pitting against each other younger people that would be saying, well, why am I out of a job? Why can't I go to school when it's really not affecting me to the degree of, obviously, the elderly? But we have to recognize as a society, we are all in this together. And even if you're a young person, you have parents, you have grandparents, you may have other friends and family that are immune compromised, for example, and highly vulnerable. We all have to do our part. Next, please. And I think also it's been difficult for the public sometimes to understand that it takes time to see the results, of putting on a control measure, or for that matter, of taking off a control measure. And that it gets reflected, if you will, in the number of cases, which often is more immediately seen. However, still with the 2-week incubation period of COVID, it takes a couple of weeks to see any result of what we do. And secondly, then, hospitalizations that may follow a month after the person gets the disease initially. So that's a lagging factor. And deaths may occur even a month or so after a hospitalization. So you have to recognize, I think it's like a super tanker ship. You turn the rudder and maybe miles down the way it's starting to turn. The same with us. When we turn on a control measure, take off one, it's going to take a time before we see changes in the number of cases, the number of hospitalizations, and finally the number of deaths. So I think we have to recognize and again have prepared the society for that lag that it takes. Next, please. Mm-hmm. And certainly one of the things that we have learned is the impact of misinformation, disinformation, and really what has also been called aggressive anti-science, people actually against science. And we've seen the rise of the anti-vaccination movement even prior to COVID, but having been exacerbated by COVID. And I think one of the things that's very difficult sometimes to explain to folks, but I like to show a bit here in the analogy of a dangerous cliff and the guardrail for vaccination. If you look at the history, let's say, of a dangerous curve in a road, maybe 1,000 people die going over that dangerous curve every year, hitting the cliff below. Now, that's like the disease. Okay, we put in a guardrail. That's like the vaccine. Now, the statistics for the next year show that nobody died going over this dangerous curve. However, 3 people were injured hitting this guardrail. That's like the side effects of vaccine, very minor, but still exist. So some people say, oh my goodness, we've got to take down this guardrail because it's injuring 3 people a year. Well, what would happen? If we do that, we go right back to the 1,000 people going over the dangerous curve. So we have to always compare vaccines and vaccine side effects is in the what would happen in the absence of vaccination. And I think we need to try to get that point across to people. And some of the other aggressive disinformation or anti-sciences has given us, unproven treatments. ivermectin or hydroxychloroquine that have been really red herrings in this, that did not do anything in terms of improving the disease, and in fact created true side effects that were totally unnecessary to have. And I think that we have to realize that often social media is a prime problem in this disinformation and misinformation. It's where it plays out, and that we need to make sure that we're using the expertise of social marketers and behavioral psychologists in crafting our messages, and even perhaps using media influencers in trying to get out our information. One of the essential public health services, in fact, is effective communication. And one of the foundational competencies, again, this is mentioned in our book, is the issue of effective communication. Next and final, please. So I want to talk about the fact that also I think we certainly have recognized now much better the importance of the global interdependency that we have, and that the current situation where we have nations still not receiving sufficient supplies of vaccine or support for their surveillance systems and their ability to get out and get the vaccines to people has given us high opportunity for variants to arise in countries where still there's a lot of disease transmission occurring. And I will leave with this issue of from Nobel laureate Lederberg, that I think captured this, that the microbe that felled one child in a distant continent yesterday can reach yours today and seed a global pandemic tomorrow. How can we procrastinate any further or have any reservations about a common cause, one that responds to every outbreak of disease anywhere as a challenge to us all? And I think that is really what we need to do to be able, as scientists, as society, to rally behind and recognize our global interdependency.
Thank you, Bob. Thank you. So about 5 years ago, David Diadana, Robert Kim-Farley, and I got together and sort of processed, considered producing a textbook on emergency preparedness that will be like none that we have had a chance to review, that would include case studies, the actual competencies, and then linking that with the essential services of public health. What you see here is the result of over 5 years of research and hard work. Some of those years were during the pandemic, and that's the cover that you see on the left side of the screen. The book is divided up into 3 major sections. Part 1 is the fundamentals of public health emergency preparedness, which goes into some of the things that I discussed today, as well as many others. And then part 2, lessons learned from actual incidents. We invited authors who had experience with case studies covering many types of actual emergency events. And we asked those authors to consider, during the drafting of their chapters, to consider the competencies required to occupy roles in public health and consider the essential services of public health. I'll tell you a little bit more about that later. Part 3 is special considerations that would include law, access, and functional needs, and other concerns. In the next couple of slides, next slide, please. Next couple of slides, we'll share a snapshot of the contents in brief, because we eagerly want to get to your questions. Chapter 3 is All Hazards Preparedness Design, a Systems Approach, is penned by Glenn Mays, one of the luminaries in emergency preparedness in the country. We invited him to pen this chapter, and we're so grateful that he decided to oblige us. But this chapter examines the key principles and practices in designing emergency preparedness systems that can address a variety of health threats, and it uses an all hazards design. He also maps stakeholders' functions and their relationships, and he compares and contrasts the various emergency preparedness systems that vary widely across the United States, and discusses their performance. In addition, he provides an overview of the National Health Security Preparedness Index, which is something that he is in charge of right now at the University of Colorado. And it reveals significant opportunities for improvement in national and state preparedness. Next slide, please. Chapter 17 concerns access and functional needs. I wanted to bring this one up because in this chapter, it really highlights the importance of understanding access and functional needs and the fact that so many people in the country will need help during emergencies. It's really easy to think of everyone being able to do everything robustly, but there are many people in the country who actually need help, not only the disabled, but if you think about it, an estimated 50% of the American population are children under the age of 15, are elderly over the age of 65, are non-institutionalized persons with disabilities, and are not proficient English speakers. All of these individuals and many others will need help during emergencies. In addition, we have many Americans who have chronic diseases and who are dependent upon various medicines, including dialysis machines, and that needs to be taken into account during emergencies. So we thought that we would highlight this chapter just to sort of reiterate what I talked about before, that not everyone can pull themselves up by their bootstraps during an emergency. And this is a key chapter in our book. Next slide, please. We also have a wonderful chapter penned by Nancy Blake and Catherine Goodhue on the importance of understanding the needs of children during emergencies. 23% of our population, are in the under the 18 age group. Children have very unique characteristics that must be taken into account, and they may be vulnerable in emergencies. This chapter goes into many dynamics, including reunification with parents, the size differentials, just many of the issues that emergency planners need to consider when they're planning for the special needs of children. Next slide, please. Our book has some unique features that I don't think other preparedness books have presented. At least we think it's unique. We asked the authors of our case studies to link activities in the case studies to associated competencies in public health and link them to the 10 essential services of public health. With the goal of making clear for students that take the course that uses the book, hints on what to do if they want to pursue a career path in frontline or entry-level staffing or program management or supervisory level staffing in emergency preparedness. So each of our case studies provides all of this information with different suggestions for occupying specific roles in public health if the student is interested in pursuing a career in public health emergency preparedness. In addition, we have an online resource list, an instructor's manual, and an objective test bank. Next slide, please. In our view, disaster preparedness is everyone's responsibility. Preparedness depends upon having an existing strong system in place to protect and sustain life under normal circumstances that can be resilient under strained circumstances. It is our goal to train a cadre of public health leaders who will not only understand the complexities of emergency preparedness, but also understand the complexity of society itself to meet the challenge of building and maintaining local, state, tribal, and national security. And I believe it is time for our questions. David, did you have any closing remarks?
Thanks, Tanya. Thanks, Bob. I just wanted to mention that people in the chat who have mentioned that they teach a course and might want a review copy, please take the survey at the end of this presentation and send us your information. We'll definitely get your review copy out to you. You can also contact us, and I'll show you a slide where you can contact us forthcoming here. But for questions, please send through the Q&A chat. I do have a question here, Tanya and Bob. It is, how can local public health practitioners support or encourage the development of emergency preparedness courses or degrees in public health programs? So I think that's a great question. Bob, since you're an academic, but also have been out, as a practitioner, what are your thoughts on that?
I think a number of things can happen. First of all, I'm very much supportive of the academic public partnership, so that if local health departments, would reach out to schools of public health or programs of public health in their jurisdictions, it's really helpful to be able to provide guest lectures, but also then to work with them on preparedness and maybe develop courses on preparedness, and even involve students doing internships in the preparedness departments within the health department. These sorts of things, I think, would help foster and encourage a more robust interest in public health preparedness, and also establish that partnership, which in an actual emergency could be extremely important too. We, for example, in Los Angeles have used students to help on some of the door-to-door knocking on with West Nile virus, for example, or contact tracing for the have come from many students in our jurisdiction.
And then I'm just building on that a little bit. I think schools of public health should really emphasize public health emergency preparedness more, not just specific schools of public health that focus on this and have a big program, but even smaller programs should add at least a couple of courses in emergency preparedness, so that will create awareness among students, and then link up with health departments to fill those internships, create those internships.
All right, thank you both. Another question I received. So what, kind of building off of that, what skills do you think are most important for, public health students and future graduates to hone, given the challenges you've outlined of preparedness and, the many sectors involved?
Well, I guess, as Bob mentioned, we need students skilled in the behavioral sciences, the biological sciences, and the political sciences as well. And even if you think about schools of sociology, anthropology, and other related disciplines, they should include a course in public health emergency preparedness to start everyone thinking about preparedness. I mean, it's really up to us, the us is a big us, like the US, the United States. We all need to get involved with public health emergency preparedness, because the threats are real, the threats are more numerous, and we can't afford to let anybody just sit back and not be prepared. So engaging other types of social science programs to include courses in maybe the sociology of emergency preparedness, or the anthropology of preparedness, the behavioral science of preparedness, and then continue to encourage people to do research toward that end, to make sure that we spread the word out and get the country as a whole more prepared. And I think that will add to the sensitivity to the people in mass, to just understand how complicated our society is, and really how vulnerable it is if we learn about all the different issues in that pyramid that contribute to preparedness.
I think also, in one sense, again, that's the uniqueness of the book, as Tanya had mentioned, we actually go forward and show all the different 22 foundational competencies that are really important to be able to address public health emergencies. And just to mention a few is that, that communicate audience appropriate public health content. The idea also of being able to interpret results of data analysis for public health research, policy, or practice, and being able to apply leadership or management principles to address, a relevant emergency issue, and being able to apply awareness of cultural values, the practice of design, implementation, and critiquing of public health policies and programs. So I think these are just some of the again, competencies that are necessary to develop as we move forward.
Great, thanks both. I think a good question maybe to end on is what ideally is the future of public health emergency preparedness, given the last couple of years, but also the many threats that you've outlined and the overlooked threats as well.
Mm-hmm. Well, I don't have a crystal ball here that I can just see the future, but I think that if we create awareness in the general population and in the schools of public health, how essential it is to really understand our vulnerabilities, I think we can inch toward improving preparedness just by creating, waking people up out of a out of a false sense of security, thinking that everything is going to be all right. Well, everything is going to be all right if we make it all right. We need to just take responsibility for being prepared, teaching preparedness, and then getting involved in preparedness activities. As I mentioned before, in my community in particular, most of the people don't have any clue what kind of preparedness activities are going on. People in my neighborhood, I queried them, just to see how much they knew. They don't know, and they're kind of oblivious. They're caught up in their everyday lives, which I understand. But with the emerging threats and the conditions in the economy and the sort of the struggle, we need to really be aware of what is going on and potential threats, not to be afraid, but just to be smart.
I think also, in one sense, we need to really work on how to keep, again, front and center the issue of public health and what it does for you in the public's mind. For example, after 9/11 and anthrax attacks, for example, there was tremendous funding put into public health, billions of dollars, really was strengthening public health preparedness, all hazards approaches, and the ability to have funding for drilling on those preparedness plans. But unfortunately, over time, people's memories wane and, funding started to decline. And so, we had, for example, here in California, we had a fairly robust state strategic stockpile of things like PPE, things like this. And it was costing $5.8 million a year just to maintain it, to roll out the ventilators, make sure they're still working, look at the portable field tents, make sure there weren't any holes in the canvas, that sort of thing. In 2008 or 2009, though, when we had the economic, crises that was occurring, legislators, and administrators were saying, well, 5.8 million, that's a lot of money. Let's just go ahead and give it off or sell it off. And so when we had the need for COVID, the cupboard was bare. It wasn't there. So I think that we need to somehow do a better job of involving the public and keeping them involved. So, it's fresh now in people's minds about COVID, but I fear in the future it could wane again. And so we need to be sure that, I think one of the things is developing preparedness plans and drilling them and involving the public in the drilling of them. That's right. For example, being able to help practice our setting up of our points of dispensing, like we did for COVID vaccines, setting up a few of those for annual flu vaccination in some places, so that people, again, experience that, and we have our public health professionals being trained in it.
And just building on that a little bit, Bob, I think we should consider that many of the health departments that are out there all over the country are really small mom and pop shops. They don't have a lot of resources. The ones that are in California and New York are large with big budgets, but many of the smaller states with smaller populations have correspondingly small health departments. I think we should emphasize getting the resources that these health departments need in the future and not forget about them. Even though they're small, they could potentially have a disaster and they're under-resourced. So we don't want to forget about our small public health departments that serve a lot of our rural areas, and to make sure that they have the resources and the staff available to meet the needs, to meet their general needs, their regular routine needs, as well as the needs during an emergency.
Great, thanks both. I think that's all our time, but here, thanks for joining us, all the people on this webinar and all the future viewers. We hope you enjoyed it. Please visit us at www.springerpub.com/public-health-emergencies for more information about the textbook and to request a review copy or to even purchase the book at a discount. Also, feel free to send us questions or comments through email. And please do take that survey at the end. We'd love to hear your feedback on today's presentation. Thanks again. And thank you, Tanya, Bob.
Our pleasure. It was
You're welcome. It was a joy. Thank you. Thanks everyone for attending.